So thank you very much for coming. It's always a great pleasure to come to these patient events. I think one of the key messages you may have already clued into tonight is that kidney cancer is a team sport. It's not just the surgeons, it's not just the oncologist. It's really a team of specialists which have to work very well together in order to guarantee you the best possible outcome. And when we talk about these issues, I have Alan on speed dial and vice versa, because we talk often several times a day about patients to get quick decisions and move patients along in their path to hopefully a successful treatment. And that is something which becomes increasingly important when the more information we have about these tumors and the more we can do, the more this teamwork is required. And we bring new people on board like Alex so that we can optimize the outcome for our patients. So just a quick introduction. I'm a medical oncologist. I came here to Vancouver 14 years ago now, in 2004, and I specialize in genitourinary tumors. So my research focus is kidney and testicular cancer, and I was privileged to really be in kidney cancer research and kidney cancer development in the last 10 to 14 years, because the kidney cancer world for medical oncology really has significantly changed in that time period. So how is kidney cancer treated? You've already seen that we have a variety of different treatment options. And really the treatment depends on the stage of the cancer. If it's a localized cancer, then Ellen is your physician. It's really surgery which dominates that field. If it's very small tumors, you've heard from Ellen that there are other options. Sometimes we can watch patients, as Ellen pointed out. Sometimes we can even watch patients if they have metastatic disease. Kidney tumors are very interesting kidney cancers because, in contrast to a lot of other cancers, they seem to have a very variable biology. What I mean with that is there are patients who have known metastasis, but the metastases don't grow for prolonged periods of time, sometimes years. And then on the other extreme, there are patients where metastases grow very quickly. In other cancer types like bowel cancer or stomach cancer, if patients have metastasis, they usually progress at a certain pace if you don't intervene. In kidney cancer, it can really be all over the place. And that is something which we need to keep in mind when we treat patients, because sometimes we don't have to immediately start chemotherapy or treatment with one of our new treatments. Sometimes we can just simply watch patients. Radiation therapy is something we increasingly utilize. For the longest time, kidney cancer has been regarded as radiation resistant, which means radiation doesn't really do much to these tumors. We've used it always for particular problems such as bone metastasis or brain metastasis. But in radiation oncology, as in all the other areas, we have made a lot of progress, and there's a lot of new radiation techniques called stereotactic radiation or cyberknife. You may have heard these kind of things, which are able to deliver a very high dose of radiation to a very distinct area with very little side effects. And that is something which we increasingly utilize and which seems to do a very good job even in kidney cancer. And then we have chemotherapy, and I put chemotherapy in quotation marks because what we use in kidney cancer is not the classic chemotherapy which you hear from other tumor types and which you always read in the newspapers, which cause nausea and vomiting and diarrhea and all these things. So we use targeted agents, and they are called targeted agents because they are supposed to target a certain mechanism in the tumor cell, which is responsible for the growth of the tumor. And then the newest treatment on the horizon is what we call immunotherapy, and these are treatments which are meant to activate your immune system to attack the tumor and get rid of the tumor, and we will talk about that in a little bit. So that's what I meant when these are the definitions of these things when we talk about that. When your doctor talks about targeted agents, so those are agents which interfere with a specific mechanism in the tumor. And those mechanisms are important for the survival of the tumor cell, for the growth of the tumor cell, and for the spread of the tumor cell. So what we're trying to do is we try to block that mechanism, which then subsequently hopefully prevents the cancer from spreading and further progressing. And immunotherapy are the newest variety of different agents which are meant to boost your own immune system. And when I say boost, that means that we're trying to make the immune system again sensitive to the tumor and attack that tumor. Because obviously, when a tumor arises in your body, something went wrong with your immune system. Because all of us, Dr. So, myself, everybody in this room, we develop cancer cells throughout our life. What happens is our immune system recognizes them, kills them, and the problem is solved. So obviously, if you develop cancer, then something went wrong there. And we know now increasingly, we have increasing knowledge of how tumor cells do that. And if we know how they do that, we can try to design treatments which interrupt that process, this hiding process, and make the tumor visible again to the immune system, which allows the immune system to attack the tumor and hopefully get rid of them. So how do we define our goals in kidney cancer treatment or in oncology? And if you go on the internet and you read about the newest studies and things like that, you will come across all these vocabulary. So we try to shrink the tumors. That's what we call a response rate. We try to prolong the interval without tumor growth. That's what we call progression-free survival. We try to prolong the lifespan of patients. That's the overall survival. And then we have the term cure or long-term remission or lasting complete remission. That is all kind of the same thing when the tumor completely disappears and does not come back. Just so that you understand what your oncologist may talk about when he uses these words. So what are the currently approved treatments in kidney cancer in Canada? For first-line use, so when we talk about treatment, and this is what I do as an oncologist when I see a new patient with kidney cancer. I sit down, I study the information of the patient, I talk to the patient, we discuss treatment goals, we discuss what is going on, and then we have to make a plan. And the plan is not just, what are we going to do now? The initial discussion process and what goes on in my head is, how can I line up as many different treatment options as I can so that hopefully the patient has an optimal outcome? And that's where these terms come in, first line, second line. So first line is basically, what do I use first in the treatment of a metastatic patient? Second line, what I use second if the first line doesn't work or stops working, and so on and so forth. So for first line use, we have sunitinib or Sutent. That is the most commonly used drug in Canada and has been with us for about 10 years now, and was a very successful drug, pazopanib or Votrient, and then sorafenib or Nexavar. For most patients in Canada and BC, it will be either sunitinib or pazopanib. If those drugs don't work or stop working, then we can use axitinib or Inlyta, everolimus Afinitor, or nivolumab, which is called Opdivo. And then for third line, we only right now have nivolumab or Opdivo if patients have previously failed 2 of the NIP drugs, so sunitinib or pazopanib and axitinib. Then we can use nivolumab third line. And that already shows you one of the problems or one of the issues we have in Canada. There's a limited number of drugs approved and funded in kidney cancer. And that's one of the reasons why it is so important that we really have a good game plan in the beginning, because we need to try to optimize each of these lines of therapy in order to optimize the outcome. Most of these treatments have, unfortunately, very little potential to cure you. Most of these treatments are geared towards controlling the tumor as long as we can. That may change in the future. I think the immunotherapy part, and we will talk about that in a little bit more detail, has the potential to cure a certain number of patients where the tumors hopefully will stay away. Sunitinib and pazopanib and axitinib have that potential too, but to a much lower extent. So the main goal of these treatments is to control the tumor for as long as we can. And we have been very successful with that. Because we now have patients who can live with these, using these drugs for years. So one of the problems we already discussed, or one of the issues we discussed when we talked about Alex's talk is, well, how can we predict whether a patient will or will not benefit of one of the drugs? So ideally, you would measure something and you would then be able to say, well, this patient, because of that, X, needs drug Y, or because the patient has characteristic B, he needs drug C. That would be ideal. Unfortunately, there are very few drugs in oncology where we have something like that. We call those things a predictive biomarker. And in kidney cancer, unfortunately, to date, we don't have that. So when I use a drug, I know that a certain percentage of patients will benefit and a certain percentage of patients will probably not benefit. But I'm not able to say, you as an individual patient, you will or will not benefit. We basically have to try and see. And this is the concept of predictive biomarker for therapies in kidney cancer, and unfortunately we don't have that yet. This is probably the most important field of research we have right now, and that's why the things Alex does is so important, because hopefully one day he will be able to tell me after a simple blood test, Christian, for patient Mr. Smith, sunitinib is the best drug, or axitinib is the best drug, or pazopanib is the best drug. And that's where we really have to go in order to optimize outcome. What are new drugs which we are in the process of, the drugs which go through the regulatory process in Canada? There's a drug called cabozantinib or Cabometyx. It's also a pill like all the NIPs. You get the pictures, sunitinib, pazopanib, axitinib, cabozantinib. We are not very inventive when it comes to these drugs. This is similar to all the other NIP drugs. It's a treatment which is meant to be given continuously as a chronic long-term treatment, basically as long as the patient benefits. Can be given as outpatients. We need to watch these patients. Any patients who is on a NIP needs to be watched closely for side effects, because we need to make sure that we can maintain your quality of life and that you don't have too many side effects. And cabozantinib is a little bit of a different NIP, because it blocks a variety of different mechanisms in the tumor cell. All of these drugs don't just block one mechanism, they block a variety of different mechanisms to a different extent. And that's why we sometimes can use these drugs one after the other, because they seem to work one after the other. And for cabozantinib, a study, the so-called METEOR study, has shown that. This was a study which was done in patients who had previously had 1 or 2 treatment with NIP drugs. And at that point in time when the study was done, everolimus was the standard of care, what we used mostly in these patients. And cabozantinib was compared to everolimus. And what did that study show? Why are we now so excited about this drug? Because the study showed that cabozantinib was superior to everolimus in terms of shrinkage rate. So more patients on cabozantinib had tumor shrinkage, better response rate. Cabozantinib improved the tumor growth-free interval, the so-called progression-free survival. And most importantly, cabozantinib made patients live longer. So the overall survival was improved. At the same time, cabozantinib was reasonably tolerated, and it appeared that patients were able to cope with the drug and the potential side effects. What are those side effects? It's fairly similar to the other NIP drugs. If we have patients in a room who have taken these NIP drugs, you will probably be quite familiar with these side effects. They can cause more tiredness. They can cause an elevation in blood pressure, which is usually not a big deal because we can control blood pressure fairly nicely. They can cause a sore mouth, some indigestion, diarrhea, some skin rash. They can cause something what we call hand-foot syndrome, which is blister formation on hands and feet, and a large variety of other side effects, but those are probably the clinically most common ones. That is also the reason why patients need to be seen fairly frequently, in particular in the beginning. When I see a patient and start a patient on one of these new drugs, I usually see them about every 2 weeks for the first 6 to 10 weeks, just to make sure that we stay on top of the side effects, that we modify the treatment so that the patient can tolerate the side effects. That usually takes about 6-8 weeks, and then we have a fairly stable, hopefully a fairly stable situation, and we can see the patient less frequently. The other new drugs on the horizon are the immunotherapy drugs. And the ones which are currently used in kidney cancer and hopefully will be used soon is a drug called nivolumab or Opdivo, and a drug called ipilimumab and called Yervoy. Ipilimumab is a drug which is already used in other tumor types, like in skin cancer, in melanoma, and nivolumab is now being used in a variety of different cancers as well. How do those drugs work? Well, usually the immune system is supposed to differentiate between your own body cells and foreign cells, and is supposed to attack the foreign cells and take care of them. That's how we fight infections. That's how we fight cancer. And that usually is supposed to work in a way that the normal cells are left alone and healthy, and only the foreign cells are attacked. And in order to do that, the immune system uses certain checkpoints. Those are proteins and mechanisms, molecules, which need to be activated in order to trigger an immune response, and other checkpoints need to be triggered in order to tame the immune response, because you don't want to have an overshooting immune response. You want to have an immune response, take care of the problem, and then the immune response is supposed to stop. If it doesn't do that, then you can get autoimmune diseases, rheumatoid arthritis, or others, autoimmune hepatitis. So those are diseases which occur, which are based on an overshooting immune system reaction. Now, the problem is that cancer cells find ways to hide, and the way they do that, or one way how they do that, is that they exploit those mechanisms which are meant to tame the immune system and prevent the immune system from an overshooting reaction, and they use those systems to signal to the immune system, don't attack us, we are part of your body, we are supposed to be here, and we are not supposed to be attacked. So what are nivolumab and ipilimumab do? They are so-called checkpoint inhibitors. Nivolumab targets a checkpoint which is called PD-1, or programmed death receptor 1, and ipilimumab targets another checkpoint which is called CTLA-4. They are some of these checkpoints inhibitors. They are supposed to tame the immune system and keep the immune reaction in check. In a normally functioning immune system, they are off switches. They're supposed to say, now the immune reaction is over, please stop, so that we don't get a problem. And if we block those signals, if we block those stop signals and trying to enhance the immune response, then that can lead to an attack on cancer and cancer cells, and hopefully take care of that tumor. This is a little cartoon which kind of shows that. What the cancer cell does, as you can see here, the tumor cell expresses certain proteins on the surface. That's how cells communicate. They express proteins on the surface and signal to other cells around them what they are, who they are, what they do, and so on and so forth. And that's what tumor cells do. They put little proteins out, PD-L1, and that is recognized by your immune system, by a T cell. Those are the important members of your immune system. And that connection here between that receptor on the T cell and the PD-L1 protein on the tumor cell is basically the signal, oh, we belong to you, don't attack us. So what can we do knowing that? Well, we can build what we call monoclonal antibodies, which block that receptor or here this protein, and by doing so, we can prevent those two partnering up and creating that signal which prevents the immune system from reacting to the tumor. And that's what those drugs do. They prevent that reaction, and by doing so, the tumor becomes visible to the immune system again, and the immune system starts to react to the tumor. So I think what we are seeing right now in oncology as a whole and in kidney cancer is just the beginning. I think the next decade will be completely dominated by these immunotherapy approaches. And nivolumab and ipilimumab and similar drugs are just the beginning. There's a rapid research and rapid development ongoing right now, which looks at a variety of different ways how to manipulate your immune system to attack the tumor. And I think that is certainly something which gives a lot of hope for us as oncologists and for you as patients, because it appears that this is potentially a treatment which actually has the potential to cure patients and put patients in what we call a long-term remission. Nevertheless, from a practical point of view, this is also treatment which is usually given continuously. Most of them are IV treatments. They are not available as pills. So patients have to come in every 2 to 4 weeks to get these treatments. It can be usually given as outpatients. And the treatment needs, similar to the NIP drugs, patients need to be watched for potential side effects. In general, these drugs are fairly well tolerated until they are not. That's what I always say. Because from all I explained to you right now, of course, if you block the stop switch in your immune system, what can happen? You can get an overshooting immune reaction. And then you can end up with one of those autoimmune, how we call them, when your immune system starts to attack your own body cells and systems, then you can get these kind of side effects. That can be that you get an inflammation of your liver or an inflammation of your bowel, a hepatitis or a colitis. In those inflammatory processes, that's what it usually is, that reaction can affect any organ or any organ system in your body. And that's what we have to monitor. And that's what we have to be aware of. And that's what we have to intervene early when we see that, because that could potentially be even life-threatening if it is not treated appropriately. So what do these drugs do? And this is brand new data, which was just published about 4 weeks ago. This is a study which was done in patients who never had treatment before, what we call treatment naive or first-line treatment. And those patients were treated with either a combination of this nivolumab plus ipilimumab immunotherapy, and the comparator arm was sunitinib, the standard treatment which we are currently using for these patients. And this was done in a group of patients with certain characteristics. About 70% of our patients have those risk factors. When we look at the patients with metastasis as a whole, we know that not all patients will do the same. There are certain factors which can influence outcome, and we can differentiate between a good and intermediate and a poor risk group. That's how they called. It's basically nothing, but we know that if certain factors we know that patients will do better or worse. And this study was done in the patients with intermediate and poor risk factors. And that's about 70% of the population with metastasis we see. And what did this regimen do? Well, it was better in terms of shrinkage rate. It improved the tumor growth-free interval, and it made patients live longer. So the overall survival was better. And this is the good news and the really exciting news. In about 10% of patients, it made the tumor disappear completely. Now, we have not followed those patients long enough to know whether they are actually cured or whether the tumor will come back in the future. But it is at least the first treatment which has the potential to completely make a tumor go away, even if there are metastases. At the same time, this was reasonably tolerated, but as I said, patients need to be watched closely for these particular side effects, which are shown here. And these side effects are mostly the overshooting immune reactions. If a patient does not have one of those, the treatment is usually quite well tolerated. But in up to about 20% of patients and in up to about 10% of patients, these reactions can be severe. And that includes things like an inflammation of the bowel, which usually causes diarrhea, a so-called colitis, hepatitis, inflammation of the liver. This is something the patient usually doesn't notice. We usually see that when we take the blood work and look at the liver function tests. Dermatitis, aka an inflammatory skin rash, and other inflammatory processes. And that, as I mentioned before, can really affect basically any organ system in your body. So if you are a patient who is on one of those drugs and you have to go to an emergency room because you don't feel well or because you have a new problem and somebody sends you to the emergency room or it's a weekend, that's the only option you have, you got to know that you have to tell the emergency room doctor that you are on these drugs. Ideally, you call your cancer center or whoever treats you and tell them, I have to go to the emergency room, so that we can call the emergency room and tell the doctors there, you know, this patient is on that treatment, and because the patient is on that treatment, there's an increased risk and you have to act quickly. This is very important because these treatments are new and not all the doctors know already how to deal with these side effects, and sometimes these side effects are underestimated. So I personally always talk to my patients and tell them, if you're on one of these treatments, you have to speak up and you have to tell them, you know, I'm on these treatments, and you have to take that into account when you treat me. Now, an important question, of course, is, are these drugs available in Canada? As I mentioned, the nivolumab, ipilimumab, and the cabozantinib are currently going through the regulatory bodies. I'm not very concerned that they will be deemed to be worthwhile having. The question, of course, is always, what is the price and are they going to be funded? The process in Canada usually takes about 6 to 12 months from the submission of a drug to our regulatory authorities until we have it funded. And then the question will be, in what capacity will they be funded? What patients, which patients can we use these drugs? So I think, and this is where the work of Kidney Cancer Canada comes in as very, very important, and that's, I think, why it's important that we have as many members of Kidney Cancer Canada as possible, because politicians don't listen to us. We can say as much as we want what we think is good for our patients. It's you who have to speak up and say, we need this because we think it's important as patients that we get access to these treatments. Thank you very much.